Good afternoon and welcome. Today's subject touches almost every family: aging and disease, diabetes, heart disease, joint pain, hypertension, etc. Can these be reversed with lifestyle correction? And can medicines and surgery be reduced? To answer that, with us is Dr. Jolly Thomson, MBBS MD, with more than 35 years of clinical practice, founder of Life Care Center, Tevara, Cochin, and the originator of clinically supported lifestyle correction, CSLC-CAP. To begin with, the first question is, generally the feeling is after 60, diseases just happen. What is your take on that?
See, age is one thing, and the aging is actually another aspect. See, in the newer terms, it is inflammaging. Actually, these diseases are considered as lifestyle diseases. The diseases which happens when your age is all become you are aged, like the diabetes, hypertension, arthritis, heart disease, all is called like inflammatory disease. And inflammation is aging is going parallel. We can measure it. What is your calendar age may be 60 or 70, but your body age can be different, and also your vascular age can be different. So these are the things which is differentiating between the real aging and the one's real health. Basically, we should understand that healthcare and the medical care is different, and the quality of life depends on the healthcare really, and definitely in emergencies, medical care is definitely needed. But the final is the biology, your body's biology. So that with that this biology and the aging and the inflammaging and all is the latest things in the healthcare and also in the life sciences basically.
Actually, now what we see is, the lifespans are increasing like anything. At the same time, even patients who are otherwise unstable, that means they may be in a situation where they cannot, look after themselves, or they have to depend on others for everything. Even in that stage, it is possible to extend life for almost quite many years. So, what is it that the general public and patients should know about living long and living well?
See, there is two things. One is lifespan. The other thing is health span. Health span means the healthy aging or the healthy years you live. And lifespan is simply the years you live. To reduce the gap between the health span and the lifespan. So that is the most important. Many a time, what we are always looking for the lifespan. But most of the patients, because in this aging, when the population is aging, last 10 to 15 years, maybe they are dependent and suffering also. So our aim should be increasing the health span, not the lifespan itself. Because if you are not healthy, the extended life will be a burden for you. So what we want is to reduce the gap between the health span and the lifespan. That is what this clinically supported lifestyle correction CSLC-CAP is meant for actually. To improve the quality of life and to reduce the suffering. So that we should understand that now the most of the diseases comes under the lifestyle diseases. So the root cause is the lifestyle, not just correcting the numbers like blood pressure or blood sugar. Is actually in the correction of the numbers is the what we are doing in generally in the medical care. But in the healthcare, what should be done is to address the root cause. And what is the problems? What is the lifestyle which is bringing aging your blood vessels, aging your body in out of proportion to the calendar age?
When we are talking about this health span and lifespan, generally it is understood by most people or most patients that controlling the disease, controlling the problem is actually what is best possible. So they all see that their quality of life should improve by controlling the disease. How do you think the patients should think? Because when they understand that beyond controlling the disease, there are more options. And also, which type of patients actually think like that they should not only control their disease, but they should look for further options so that they don't remain a patient.
See, if a person is taking continuously on medicine, if you get a fever, you take some medicine for a short time, it's not significant. But if you're taking medication for these lifestyle diseases like diabetes, hypertension, heart disease, or arthritis, or autoimmune diseases, then you should, or everyone should, those who are taking such medicines should think, is this number control, that is, if the blood sugar or the blood pressure control is enough? And are you addressing the real reason behind that or the root cause behind that? If you are not controlling, doing the addressing the root cause, you have to take everyday medicines. You know that everyone who's taking medicine know that if you stop a medicine, say miss a single dose, the sugar will shoot up, and also for the pressure will shoot up. So it is all definitely, it can give a pressure shooting up, it can really create problem for you. So we should think beyond controlling or correcting the numbers alone. You should look into the deep problems. That is where again inflammaging is coming. Actually, it is an accumulation of inflammation, after changes in all over the body, which is giving you the driving to you diabetes, hypertension, and heart disease. All has a common cause, and we should, if you address the common cause, all these things can be corrected in the single row itself. That is what I'm saying with the CSLC-CAP, that is clinically supported lifestyle correction, in which we take a detailed account also about the all the blood parameters, not only blood pressure, sugar alone, to go deep into the insulin level, what is the level of insulin resistant, and kidney GFR, kidney parameters, liver parameters, what is the level of even fibrosis level of the liver. And we can see that if you do the correction in the biological correction, if you are focusing, all these parameters can come together and they can be corrected together. With the medicine, it is in the opposite way. You are you treat each specialist, and medication is focused on the sugar, pressure, heart, arthritis, and different, and even the operations are in that way. But the biological correction is the most important. That is what the latest studies also shows.
Actually, when it comes to many patients or most patients, they come first with one lifestyle disease. Say they will identify sugar, or they will identify fatty liver, or they will identify some BP. But at that time, they will be focused on one of that. And usually what is seen according to our studies is that normally the disease will be present in the person many a times up to 7 to 10 years before it is actually diagnosed. What it means is that the patient may be showing one disease, but they will be having all the other or many other disorders and diseases together. But they will be primarily thinking of themselves as a patient of one disease. Then after some time, they come across the other diseases one by one, and then things become very complicated. Now, why is it that all these diseases usually are said to be coming parallelly, but they are diagnosed at different stages, and then the patient never sees that there is something common between these diseases?
See, in such cases, generally, when a person is doing a health checkup, you can just to understand in a clear manner, I can give you an example also. If a person is doing blood test, we will cardiac markers, so many other, it depends on the hospital's policy, and all different markers will be looked into. I can show you one person in my clinical practice. This is a 78-year-old man, and he's already having some bladder tumor problem, but it was not a carcinoma. He had undergone surgery. It was a papillary lesion, it seems. And he's having some small ailments are there. Small ailments, he's not okay. He's okay, but he's pre-diabetic, he's having anemia, and he has some skin problems, itching, and memory reduction. Definitely, 78 years, we can. And when we looked into his details, then he's just come for health optimization. He was not having a major problem. When we looked into, he was taking medication for the light medication for diabetes and hypertension. That was the only thing he was taking. Many of the nutritional deficiencies was there, and his insulin level was high. Actually, this is type 2 diabetes only. And he's having a SGPT and SGOT. This is NASH, that is hepatitis, non-alcoholic. He was not alcoholic at all. Non-alcoholic hepatitis was there. He was not knowing that actually. And when we looked into there, he was in the stage 3 of fatty liver, and the fibrosis level was also increased. And there is AMA, that is a marker of the autoimmune marker, mainly for the thyroid, that also high. And above all, his PSA and the CEA, that is the tumor markers, cancer markers, it was also increased. But moderately only, for PSA 4.4 and the CEA 6.16. And with the clinically supported lifestyle correction, it's all corrected actually. It's almost this HbA1c came down to this 6.2. Actually, it was only mild, pre-diabetic only. He was on medicine also. Without medicine itself, he came down to 5.5 within 2 weeks. So very fast change was there. And also his GFR was reduced, and it came, it was only 77, it came up. And the PSA and the CA level also came down to normal within 3 months. And it was consistent. Within 1 month itself, it just came down. And then it is for the next 3 months, it was continuing like that. And he continued this clinical support and everything for the 6 months. And by the 6 months, parameters was almost everything was normal. Only thing, his HbA1c was not came up to normal. Only it's around 11, and he is telling that it is his base. It was always like that from his adulthood onwards. So it may be because of some other reason, and keep it like that. And after 6 months, when he came, again that PSA has slightly increased. And it was came up to after actually he has gone for a trip in the US and Australia where his children are there. And after that, again, it has come down up to 4.9, and CA came to 6.5. Again, he has taken some more support and he followed the in a strict fashion. Again, it came down. Again, after 1 year, actually, in the 2 years follow-up, the last 1 year, he was following and living a lifestyle which is he think that it is what he is taught also, but we are not taking any support. To see, and he basically again the PSA has gone up, CA has gone up. So it is, if you correct, then it will come down, and if you are not fully dedicated in it, it can go up. So definitely there is seeds of, there may be, if you look into, especially in old age, there will be seeds of cancer cells and all will be there. And if you follow it correctly, it can be brought down, or at least its activity may not be. If you take a biopsy, it may not be completely corrected. I mean, there may be become a biopsy, there may be cancerous change itself. That is what the studies also show. Around, even if the PSA is normal also, around 12% cancer, biopsy cancer can be there. So, and also this person, we did this time, the second year, we did a CIMT test, that is to show what is the aging of the blood vessel. It's also very high. He's, by the time he's 80 years, but his age, body age was, this vascular age was gone up to 45. So there is, I was discussing with him that you are having a risk of hypertension, a heart attack, and a stroke is there, and also the possibilities of a higher chance of colon cancer and the prostate cancer. But he was, his diabetes was, he was able to keep the HbA1c 5.5 and many other parameters okay, but this is the risk. So these can be, this inflammaging can be diagnosed very early, and the most important is it can be corrected also.
Regarding this word inflammaging, no? So what does it mean? What should persons generally understand about inflammaging?
See, as I said, all the diseases comes under inflammation. The body, the immune system, actually immune system is our real doctor. And whatever doctors or hospitals or the operation is done, actually healing comes from the immune system, and that is your own doctor. And your healing capacity or your health is directly depend on the immune system. Immune system has two wings. One is inflammation, that is defense. The other is healing. And defense is mediated through the omega-6 fat. Actually, we think that the protein is the most important nutrition, or the vitamins is most important, or minerals. So all are important. But finally, the immune system is controlled by the omega-3 and omega-6 fat. And inflammation is controlled by the omega-6, and the healing or the anti-inflammation, that part is controlled by the omega-3. So this balance, inflammation, anti-inflammation balance, or the omega-3-6 balance at the cellular level is the most important in the health and aging also. So if the inflammation is going up, that is actually, inflammation will come when there is toxin accumulation. That is what happens. All these lifestyle diseases come in a later age, because accumulated toxin, mainly in the form of fat itself, actually ectopic fat. This vascular aging is because of the ectopic fat, atherosclerosis. For that, that is the reason for the heart attacks and the stroke. Those are aging diseases. And this is because of the fat is depositing in places where it should not be there. Even the fatty liver, and that fatty liver is progressing to liver cirrhosis and liver failure. So fat and definitely other toxins, environmental toxins, and any nutrient also. In an excess proportion, it will also act as a toxin, like a glucose and a triglyceride. That is all nutrient, but if it is in excess quantity, it will also act as a toxin. So this toxin accumulation is the reason for inflammation, inflammaging, especially this omega-3-6 balance is very, very important.
See, when you have said about inflammaging, it appears that this inflammaging is the foundation for many disease conditions. So, how do you measure this clinically so that the person can know that if he is getting improved or not?
Yes, inflammation has so many markers. One of this is this blood count itself, that is CBC, WBC count, ESR, CRP, HSCRP. HSCRP is a very specific marker for the vascular health, if the vascular inflammation, and also the homocysteine. Homocysteine also, it's actually an indicator for the nutritional deficiencies also, and many of the B complex group of vitamins is reduced also. This homocysteine will be increased. Then this vascular aging we can definitely check with the CIMT, that is carotid intima media thickness. That is the one of the major blood vessels which is very superficial. We can directly look into with the ultrasound scan. That is the main blood vessel going into the brain, and in looking into the changes or the accumulation of fat in the below the endothelial layers. That is the way this vascular aging is calculated. And also the body aging, that is lean mass fat mass ratio. That how much actually your age is depends on the muscle and bone mass basically. And when the muscle and bone mass is going down and fat mass is increasing, there also inflammaging is happening. And other markers like this autoimmune markers and the tumor markers all are actually showing the inflammatory markers. Even the liver function test, we can see specifically when we look into, we can see the liver enzymes is increasing, that also inflammatory markers. And kidney, we can many parameters, even the leaking of urine, albumin in the urine or the RBCs in the urine. Those all are the markers of inflammation. Or if there is inflammation, only there is uncontrolled inflammation, or the body is trying to resist something. That is the sign of, so it has so many signs, symptoms, and also the lab markers are there. You can look into the lab markers and see that with the lifestyle, what we are in the clinically supported lifestyle correction on the CSLC-CAP, what we are looking into is initially we check all these things, and with the lifestyle correction, see what is happening. And it is continuous monitoring and see what is happening.
Actually, if a person identifies that they have an inflammaging status and their markers or something is increased and all that, what is it that with the clinically supported lifestyle correction they can see it gets corrected?
Yes, actually, in the clinically supported lifestyle correction, we don't take it anything granted. So that's why we take it all the, it should be evidence based. Modern medicine is evidence based basically. So, just like what is happening with the medication, here we are trying to look into what is the corrections happening with the lifestyle correction. I'll tell you an example also actually. This is the person, he's a 72-year-old man. He had a CABG, that is coronary artery bypass surgery, 1 year before he came to me. He came and he's actually a citizen, a permanent resident in the US, New York, actually. And he, after this bypass surgery, he recovered, but after he's not able to walk. That is, after 5 or 10 steps, he find it claudication pain on the leg, the calf muscles. So he was undergone test and found that there is atherosclerosis for the of the leg vessels also, and almost there is not much circulation into the this foot arteries. Almost we can see the Doppler studies, and the flow is almost very much reduced. In that stage, actually, he was advised to, the only option is to do a stenting. But this stent application is effective only if it is this atherosclerosis or the block is on the major blood vessels. He has block in the major blood vessels. It can be addressed through the, partially at least, can be addressed with the stent. But the problem is his smaller less blood vessels also is affected, and he is a long time is on medication for the diabetes for the last 35 years, and dyslipidemia and hypertension all is there. So for this person, when he came, he's basically a Malayali and Keralite, and he came down for the treatment and stayed here for he came planned for 1 month, but he stayed here for 3 months. And what was the result actually? Within 2 months itself, within a month, his symptoms actually gradually reducing. He is able to walk more and more distance without discomfort, and his diabetes, hypertension, and all was reduced. This person also, even there was this, he is diabetic, no, HbA1c high, 7.1, GFR was low, and homocysteine high, and amylase lipase, chronic pancreatitis was there. Even the CEA was increased to 3.25. And with the monitoring, actually, in the first week itself, his HbA1c came down to 0.2 reduced. And within 3 months before he goes from here, his HbA1c come down to 5.8, and without any medication. The diabetic medications only, without any medications means it's not absolutely no medication for the diabetes. Only if we take any carbohydrate diet, we should always, we have some impulse of taking or craving comes, no? Or we always ask the patients to take at least once a week a heavy meal, whatever he likes. And that occasion only he can take, that occasion he has to take this SGLT2 group of medicine. That is actually, for the diabetes, it is actually excess glucose is there. It is not promoting it to be deposited in the body. Instead, it is passed into the urine itself. So such type of medicines will be used. Otherwise, he was free of medication actually. And the important aspect, another interesting aspect also, giving happiness for the physician, the doctor, is in the second 1 year after, by the time 10 months he came again for a follow-up, and that time he was able to climb a hilltop, and it's a very difficult hill. It is called this St. Thomas Mount at Malayatur. It's a very steep and very difficult, and I also surprised that he gone there. And the person was not able to walk 10 feet, and at this 78 years, 77 years, and after 1 year with this clinically supported lifestyle correction, he is able to think of even going to the very difficult trekking.
Actually, when it comes to these markers, many times patients say that their BP was okay, their diabetes was in control, they were having checkups and all that. But when they had chest pain, they found that there are 4 blocks and they are having serious difficulty. But how is it that, in spite of having all these checkups and all that, they are able to land in such a situation?
See, general health checkup usually go for a cardiac, just usually this echocardiography will be done. In our part of the place in Kerala, generally if a patient is going for only for a chest pain, then that is everywhere I think. Chest pain or any cardiac discomfort, only go for a angioplasty, angiogram type of test or even an echocardiogram. But I can tell you one example for one of the patient also. And this person, he's a 60-year-old man. He has never had any serious illness of, and he was usually undergoing health checkup and all, but nothing was found. But for some time he was feeling some exertional dyspnea when he was doing work, and one day he got a slight chest pain and gone to the hospital and did a angiogram, and what was found is he's having three vessel disease. He was advised for an immediate bypass surgery, and he was very worried. He was never had no major health issues, and all of a sudden bypass surgery, he was worried, and that is why he came to me for to see what is the possibilities of the lifestyle correction. And when we looked into actually the CIMT, he has serious atherosclerosis in the carotid arteries also, and he's a smoker, and slight alcohol also usage was also there, and it's almost 60% flow also is reduced. So that is the situation. He is not symptomatic at all, but even the 60% flow in the carotid arteries is reduced on one side. So this person actually here also his many cardiac markers were is HSCRP, the cardiac markers HSCRP was 15.9, CRP 15.4, ESR 79, and homocysteine also high 16, and cholesterol, triglyceride and all is high. Even the troponin was high. That is the immediate cardiac risk indicating. Troponin was 72.2, and the triglyceride and all is high, and he was not knowing that, but he was diabetic also, and his HbA1c was 6.7 or so. So that is the situation, and the changes, and also it's a person who's already asked for a bypass surgery, and so every week we are following it up and taking all the precautions. If we get any mild chest pain itself, asked to take the sublingual tablets for the angina pain, but he didn't have any pain or any problem throughout, and within a week actually his HbA1c came down, and the troponin level within a week it is came down. It was initially 72, but on the 8th day itself it is 9.9. So it is reassuring for the patient and also for the physician. And by day 90, without any medicines, without medication, major medication, continuous medication, his HbA1c came down to 6. Here also, we always ask them to take medication for if they are taking carbohydrate, because he was overweight, and his height was 164 and weight was 72. And within 3 months, actually, he came down to 58 kg. That is the important thing. Since we are in the clinically supported lifestyle correction, what we are looking into the body composition. Here the body composition is changing. He had a 14.5% fat in the initially, and it came down to 7.5 visceral fat. And in the CIMT also 3rd month, there's a drastic reduction in the vascular aging, and it was in the 200s and all in the initial stage, and came down. And he's every 3 months we follow it up with the vascular aging also. And if the patient is following the parameters correctly, the CSLC-CAP protocol correctly, all this vascular aging and even this accumulation of this atherosclerosis plaque size or the thickness can also be coming down. That is what, in my practice, what I am saying.
Actually, you were saying no about some patient who actually improved his health condition, and but after some time, after going back to some of the old ways, the health condition deteriorated some portion. Now, what does that mean to actually patients? Is it that, once they are able to get improvement through this clinically supported lifestyle correction practice and all that, once they get those improvements, are they becoming more confident that, that in case something they stray from their path and their numbers and all go down, they will be able to come back to the previous condition? Is it do they get that sort of confidence, so that they feel more like in charge of their health in a way?
Yes, definitely. Many of the patients who, one good number of patients, they follow it up correctly every 3 months, and after initially first 6 months we follow it up every month, and then every 3 months for 1 year, and depends on the condition of the patient and their convenience. We follow it up every 3 months or 6 months, over at least on the telemedicine. And in the patient from US and the Australia and different part of the world, we are having patient, and we follow it up with the telemedicine follow-up. And we always encourage the patients to come down at least once in a year, because the advantage is in India, we can do the test very freely, and the test is very economical. And it is not possible in what I see is in Western and the other foreign countries, it is very difficult to get a test done. And also, if they are going privately, it is very expensive. And in the insurance scheme, it is not allowed to test like even here. We test the cholesterol and all when the patient is in the active phase. Every week or at least once in 2 weeks, till the things are corrected. Once everything is corrected, we follow it up in the initially 3 months every month. And especially when this tumor markers and all is positive, till it is coming down in a regular pattern, we will check in every week. And such facilities are not there in any part of, from my understanding, it is very difficult for other part of the world. In India, in our Kerala, that is the very major advantage. And because it is very economical also for those who are coming here because of the exchange rate and all. It's very, very economical for them. They feel, patients will feel very free to do the test. And you can repeat it and see what is the change. And with that, they will also develop confidence. And naturally, when after 3 months and all, it will, after 1 year and all, there may be, because the lifestyle will change somehow. But so there may be some increase, or the inflammatory markers or cardiac markers can be increased. But again, 2 or 3 months, we take the again active treatment will be taken, and they can come to normal again. And with then maintenance also. There are patients who come abroad from other countries, like even from African countries. Mainly Malayalis who are in the Indian diaspora is settled in many countries. No? They come here, and every month, yearly, usually they come and check it and see even the atherosclerosis plaque size is correctly reducing, and I have seen patients who is completely removed also. That is all depend on the patient's commitment.
Actually, regarding this minimizing medication, there is a general feeling that, the medications for chronic diseases have to be continued almost whole life. So we also see a lot of people saying, no, don't forget your medicines. You keep taking the medicines and all. Now, what is unfortunately what we see is many patients, they don't go back to their doctor, but without going back to their doctor itself, they continue taking their medications without any prescription. They will be having one prescription, they will be using that for a long time. So in this situation, what should patients understand about, how medications should be reduced when improvements take place, and how is it that it is done when you are having a clinically supervised lifestyle correction program?
Yep. One important thing is you should not reduce the medication without clinical support or without your doctor's advice. You should continue it. And another thing is you should consult frequently. Then only we can see that what is happening inside your body. If your lifestyle is not, if you're not correcting the lifestyle, definitely the blood sugar, if you are maybe taking a medicine, but the blood sugar may not be in the control. Yeah, the just sugar once checking is also not sufficient. If you are doing the blood sugar checking with the strict few days, you are controlling everything, and then checking, it may be appearing normal. But you should take an average of this HbA1c, that is the 3 months average. It is called a 3 months average because the lifespan of the RBC is 3 months. So you get an average what is happening in the last 3 months. So that is HbA1c. And the blood BP every day. Now we can check the BP, monitor BP at home. You should check every day. And if it is with the medicine, it is controlled, then it is okay. But if you correct your lifestyle and then go to the doctor, if it is usually it may come down below normal. That is why it can come down. What happens is when we do the clinically supported lifestyle correction for the BP, when the BP is constantly 120/80 or it comes down to 110/70 or 110/60, then we start reducing. And if you are a person with a 110/60 BP and you are taking all three BP medicines, it's dangerous for the patient. So one by one, we will start reducing the BP medicines. If the patient is taking BP medicine, when the patient's weight, if most of these patients will be having excess weight, and also even if it's the normal weight, there will be excess fat. When the fat is reducing, the inflammatory markers, the inflammatory agents which is coming out from the fat is reduced, then naturally the blood pressure will come down. And it is very, very important that timely reduction of the dose also is very important in the clinically supported lifestyle correction, especially regarding the cardiac point of view, this BP, and also for the heartbeat. And there are patients who, I had seen that patients who are taking this beta blockers, that is for the as a cardiac medicine and also as a BP medicine. So it will also, heart rate also will go down, like go down to 40 and 50, 40 and all. Once the cardiac rate is going down and the BP is going down, we had to take the measures to reduce the medication also. That is what the clinically supported lifestyle correction is meant. So don't stop any medicine or reduce any medicine without your doctor's advice. And also when you are taking medication, you should frequently, at least within, if you are on medication, at least 3 months, every 3 months you should visit the consultant.
You often say that any person who is on medication is a patient, and the person is actually sick, because if the medications are discontinued, the problem again arises. So what should patients who are continuously taking medications understand about themselves, because some of, or if not majority of the patients, if they are on medications and if their numbers are correct, they think that they are not patients anymore.
Yes. If everyone should, if you are, I'm diabetic, but it is controlled. What is your HbA1c? It's 7.7 or 7.5. That is, or 6.5. That will be the answer from the most of the patient. They think that they are okay, but it is the real okay. If you're really healthy, that means your HbA1c should be around 5.5. And the blood pressure should be normal, and you should not be taking any medicine. Then only you can be healthy. That is healthy aging. If you are on medication and you are means it is you are sick, you are diabetic. Again, you are diabetic, and inflammation is going along. So inflammaging is happening. So it will gradually erode your health. This you may not be symptomatic initially. That is the norm with the lifestyle diseases. It will show the become symptomatic only at the end. Initially, there will not be any symptoms, and for the diabetes, there will not be any symptom, and only the polyuria and polydipsia sort of thing comes in the late stage when the sugar level is so high, 300, 400, 500, and all. So we have seen such patients. But even those who are on 500 HbA1c, 500, I had one patient last day. It was HbA1c was above 500. And within 2 days, he was able to bring down with the clinically supported lifestyle correction to 180, 160 range. And actually, occasionally it was going up like that. And within, it was basically around, we always ask for the HbA blood sugar control around 70 to 140, below 140 after food. That is the ideal thing. That is, if you're keeping like that, inflammaging will be reduced. Your aging, your biological aging will be reduced. So it is the biological aging which matters your health. So it is not the life expectancy. Actually, it is the healthy life, health span, not the lifespan, which is more important.
See, another major event or time when patients have to understand very clearly what is their options, what are their options, is when a patient is told a stent is needed or 4 stents are needed, or say a bypass is needed, or angioplasty is needed. So at that time, generally, if it is an emergency, of course, it goes ahead immediately. But otherwise, what is it that they should understand about what these procedures do for them?
See, medication and procedures are an immediate, it's actually medical care basically. It is not health care. For example, if you are overweight, naturally for a long time, and if you are overweight and your knees will be becoming weak, and especially the cartilage will be thinned out, and you will be asked for a knee replacement surgery. And I'll tell you an example with many of a patient itself. This is a 78-year-old man. He had undergone initially stenting, that is angioplasty was done. Then again, it was recurred, and he was advised for a bypass surgery, and the bypass surgery failed. And he has put on around totally around 10 stent was in his body, in his cardiac coronary arteries, and the bypass is done. And now his this beats are reducing, and he was advised for a pacemaker surgery, pacemaker implant, and he has a major knee problem, and his only option is the knee replacement. So he is not able to, even after this all this angioplasty and bypass surgery and all, he's not able to this angina, frequent anginal attacks, and he can not able to walk more than 5 or 10 feet. And by the time he has to stand and again stop and take breath, and then only he can take the tablet. And that is the situation, and he's finding it even difficult to taking bath and all. And when he came, actually, we are looking into the details, and even all the many vascular markers are high, and even the troponin was high, 37.18, and the kidney function also down, 54 only GFR. And with the insulin, so many medicines he is taking, around 14 medicines, and multiple times more than 20, 14 means around 24, more than 20 tablets he is taking for the diabetes, and also insulin, diabetic medicines, tablets are there. This metformin and tenactin, and the insulin twice a day, and for the heart, cardiac, ecosprin, Brilinda, Nicoram, Isonome, Renosex, that is Ranoselecin, and nitrocondin, and so many medicines for the cardiac aspect also. And this patient, actually, with the lifestyle correction, and he was within, by the, I'm not looking into the long, making it short. By the 3 months, without any medicine, his HbA1c has came down to 6. And the body also, and he was able to, and he was came with the stick and all, with the difficulty, and without stick, he is able to walk. And he's able to do all the routine work. He is not finding it difficult at all for the age. And the body change also, you should understand that he was not overweight. He is 167 centimeters and his weight is 68 only. But by the 3 months, he came down to 56 kg. And his visceral fat came down from 12 to 4.5. And that is the change, that the visceral, the excess fat has to go, and the muscle mass actually increased. So proportionate increase in the muscle mass also is taking place. With the structured, this is happening with the structured exercise and the optimal nutrition, and also reducing the toxin level.
See, what is, see, you mentioned this CSLC-CAP, clinically supported lifestyle correction, cell activation program. What exactly is, what is it constituted of?
See, our body basically needs nutrition. Our body is built of basically what you eat, and the nutrition in the optimal proportion. That is the one aspect of CSLC-CAP. We are ensuring the patient is getting all the nutrition in the correct proportion, especially this anti-inflammatory or the healing omega-3 is in the very good percentage. And the omega-6 is, and we are also looking into that omega-6 is also not high, and we are trying to make it in the proportion 1:1. Next is the physical activity. And many patients, like they are already undergone bypass surgery or they're having angina, they cannot do hectic exercise or anything. So we have a planned exercise pattern itself. It can be done in the lying down or the sitting position, and comfortably done for all these arthritis patients, knee pain, and although even the angina patients, they can do it. And that is optimal exercise. Then reducing the toxin level. That food, we are in the modern food it is refined, and also many food additives like color preservatives, tastemakers, those things are also, it is a burden for the immune system. And also this, many of these patients will be having a compromised liver, fatty liver, or the fibrosis, and the kidney, this GFR is gone, came down, and the microalbuminuria, urine albumin will be there. So such patients, this reduction is another aspect. Then the fourth thing is the rest, and enough rest and sleep. And we always advise the patient in the initial stage, when the healing phase, give 8 to 10 hours of sleep. And generally we say in the 8 hours sleep, but very sick patients we always promote to sleep for around 8 to 10 hours. So if these circumstances are given, then definitely the body, we are empowering the immune system, your own doctor, your biology, improving your biology, and your own doctor, the immune system will take care of you. So empowering the immune system is the basic thing which is done in the clinically supported lifestyle correction, and it is monitored in the correct way. And it is very important that reducing the medication also is very important in this, because this inflammatory and all anti-inflammatory pathways are in parallel. What all medications we are taking, even the immunosuppressant or the aspirin you are taking for the blood thinner, it's all anti-inflammatory. It is actually suppressing your healing pathway also. Even the statins we are taking, it is actually blocking the synthesis of the cholesterol. But to make a new cells, the cholesterol is also very important. So the adequate amount of cholesterol also should be ensured. So we, with the clinical monitoring, with the lab test, we try to reduce all the medicines, not whatever medicine is there, to reduce it to the minimum dose for the timing. And usually in my practice, what I'm saying is almost if this patient enroll is actually came reduced medication by the 90 days, only the occasional medicines like even the cholesterol medicines, it was he is taking 40 or 50 80 milligram, brought down to 5 milligram, usually 5 milligram daily or alternate days or weekly twice. That is the norm we are keeping, and it depends on the patient. That also, if the patient is very seriously following these things, it can. But some patients will not be they are traveling and all, may not be able to stick to very much into that. In that case, we ask them to a very low dose of statin, or even if they are taking high carb diet, and then that time it's all okay. When according to their diet or medication, that also in SOS manner, that is necessary. That is the pattern, and the patients are able to follow in that way. Only those who are able to follow such things is fit for this. Otherwise, if you are not disciplined and you are not willing for the lifestyle correction, then we will not take such patients. And we are looking that when they say also, if the lab reports is not saying, the lab report cannot say, it will be giving the correct internal mechanism what is happening. Then we can understand also if the patient is not following or the lab report is not accordingly, then he cannot come out reduce the medication, or we cannot reverse the biological process as such.
See, what happens is for many people, they will see this approach as trying to improve the foundation of the person's health, but at the same time not the conventional approach of disease treatment, wherein medication is given, or wherein some procedures are done, or surgical matters are done. So how is it that for such people they should understand whether this is, they may mistake it for, say, naturopathy or Ayurveda or Unani and all, where also modern medicine is not included and surgery is also not done as in conventional modern medicine. So how is it that people should understand this?
See, CSLC-CAP is basically modern medicine based. Is the in the first step of any disease management, the modern medicine itself saying this is lifestyle correction, because all these, according to our understanding, the modern medicine and the modern life sciences, this is all lifestyle diseases. So here we are giving a structured lifestyle correction based on the modern medicine aspect. We are not using any in the whatever medicines we are using is only on the modern medicine. Only nutrition and the modern medicines only we are using. And it is not Ayurveda, we are not using any Ayurveda, Homeo or Unani or any Ayush type of treatment we are using. So only modern medicine, and based on the modern medicine, only the approach is to reduce medication and the surgical intervention. That is the general aspect of the modern medicine itself. Actually, the father of modern medicine, Hippocrates, said that if you can find the correct amount of nutrition and exercise, or if you can give correct amount of nutrition and the exercise, then that is the safest way of health. And also his own quote is supposed to be his own quote. And also in Indian medicine also it is said that the food is medicine, the medicine is food. So that is that foundation. From that foundation it is also coming. It is based on modern medicine foundation, and it is all the parameters are checked according to the modern medicine system. And also the supervising doctors are MBBS, are basically MBBS and MD also. No, that is the MBBS MD. That is the basic qualification in India is the MBBS, and usually in other things with the specialties going in. But basically modern medicine qualified doctors are supervising it also.
See, when we talk about this, especially when those we are talking are having age on their side, so which type of patients cannot actually benefit from clinically supported and supervised lifestyle correction?
The first thing is the patient should be interested in, or she has the willingness for the lifestyle correction. Second is he should be in the reasonable health. He should be ambulant and also in a clinically stable situation. Not if you're very sick person, they need the ICU care itself. Only after stabilizing the patient, clinically stabilized patients only can have this. And they have the mental, the physical, physically they should be stable and have the basic capacity to do the exercise in the activities what we are teaching in the lying down or the sitting position at least. And also they should have the mental capacity to learn this. If a patient who is a psychiatric patient who is not under control, we cannot teach them or monitor them. So the patient should be having the basic physical and mental capacity should be there. But if the patient who is having some memory deficit and early stage of Alzheimer's disease or dementia and all, if the one of the family member who's taking care of them is also willing to enter in this program and learn and support him, there also it is possible. Because we get patients whose husband or wife may be having some dementia problem, then the wife is having dementia, then husband also, and they both of them they can manage. Even they will be able to manage in that way. So one more person who's very close also should have. And also when you come to the children, it is very difficult to, less than 10 years, we don't really usually take. And also for the minor, between 10 and 18, if the patient, one of the parent has to also join in, because it's a family affair also. The children, they cannot do the lifestyle correction only with their parents' support. If the parents are not only fully dedicated, only the children will get the result. So that is the basic. And also, if the most difficult is the renal failure, the disease-wise, the renal failure, if it is the early, even stage 3, 4 and all, it is no problem. But in the stage 5, if the patient is stable and no other major problems like cardiac failure or anything is not there, then even the patients who are having creatinine 5 and all we will take. Usually you don't take below above 5 creatinine level. So that is because the kidney, when the kidney problem is there, we cannot give the nutrition in the correct proportion. So it is very difficult for a repair and regeneration of the body in a renal failure, especially in the end stage of the renal failure. So such patients are not, those are the exclusions actually.
With this, we come to the end of the live. Hope you have had a good understanding about aging and inflammaging, and most importantly, what we should know about inflammaging, so that we can take measures to control, manage, and maybe even reverse it. And most importantly, how this simultaneously helps many diseases across different specialties at the same time. Thank you.